Hello everyone. Welcome at Sudhir I Coach, a channel for budding ophthalmologist. Today I'll be sharing an interesting video of how radial keratotomy affects phacoemulsification. First thing, during surgery we have to be cautious about the selection of the site of incisions. We have to avoid previous scarred incisions. Luckily in this case the incisions were apart, so I selected two side port incision sites which were quite apart from the previous incidents. I created a decent sized capsular axis of around 5.5 millimeter. Performing a capsular axis is not a difficult task, especially when you enhance the retroillumination. I placed myself in such way that I can create 2.2 millimeter clear corneal incision uh, in between two previous incisions of radial keratotomy. As you all know that radial keratotomy is a surgical procedure to correct nearsightedness or myopia. The technique was first developed by Russian eye surgeon Sir Fodorov in 1970s. If you are getting proper sight of a clear corneal incision, you can make between two radial keratotomy incisions. However, clear corneal incisions made too close to radial keratotomy or too central are at a higher risk for further inducing irregular astigmatism, possible worsening of aberrations and loss of structural integrity if they cross the radial incisions. The rest of phaco surgery almost remains same as we do in a normal case. But obviously in preoperative period, taking keratotomy readings is a difficult task because of too much flattening of central cornea. Here I used Master 700, which does 4 millimeter topography as well, and I compare it with the using the Pentacam EKR values of different diameters, and both were matching here. So I selected Master readings for radial keratotomy, and Master was not accepting the radial keratotomy mode. Therefore, I calculated on the Barrett suites and added +3 diopters to achieve IOL power. And because too much of flattening of cornea creates hyperopia, therefore always target -1 or -1.5 diopters of myopia in post-operative period. So rest surgery remains same. I cleared the epinuclear plate and implanted the single piece hydrophobic implant in the bag. And before closing, always check any incision if they are uh, gaping. If there is a gaping, then you can place a suture here. Luckily there were no breach in the integrity of corneal incisions. As we all know that incisions are weaker, and sometimes the similar kind of echo settings can create a gaping on in the wound, so you can reduce the echo parameters. Here I use the similar echo settings and completed my surgery without any problems. Thank you very much.